We're good to go. Take her away, Doug.
Thank you, Matt. Good to be here. Nice to see everybody. Thanks for the invitation. Dr. Shannon Gollnick and I are going to tag team this. I'm going to go ahead and screen share for the Death by PowerPoint. Hopefully you are seeing it okay. And I assume somebody will speak up and tell me if you're not, but just the same, I again appreciate the invite. And our subject today is documentation, education, and field provider buy-in.
Hey,
So
Doug.
we're not really going to talk about, strategies for how to document and write good PCRs, but we are talking really from a leadership perspective, because documentation is really one of the dragons that most agency leaders say is the most challenging one to slay. So we're going to look at this from the leadership perspective, and like I said, Shannon and I are going to tag team that. Matt, look like you're going to say something.
Yeah, you might want to flop your presenter view with your official view because we're looking at your presenter view on the screen. You
Okay.
just switch monitors or go under display settings and flip them. Not that we don't mind seeing your notes and what's coming next because it's like the anticipation, right? So there you go. Much better.
Thank you. Just a reminder that our material is copyrighted. If you're going to steal stuff, don't do it from a lawyer. And I'm a lawyer. Shannon is a regular person, but this is not attorney-client advice, as we like to say. But we're going to talk again about the role of leadership in improving documentation. I'm going to cover 5 ways, specific strategies for leadership to help improve documentation. And then Shannon's going to talk about gaining frontline buy-in, what he calls the narrative of narration, which is pretty cool stuff. So let me start with the idea of the role that leadership takes in improving EMS documentation. And I like to always start with this reminder when I talk about this because, EMS is sort of paramilitary structure. We're very sensitive to scope of practice and rank within an organization. But I think, as we know, leadership has really nothing to do with titles, job descriptions, position, rank, scope of practice, or any of those traditional EMS things. I like to quote our 6th president, John Quincy Adams, who said, if your actions inspire others to do more, dream more, learn more, and become more, you're a leader. So I think regardless of anyone's official title, position, rank, scope of practice, or place within an organization, everyone in the organization has capacity for leadership, particularly in the areas of documentation improvement. So I always like to start out by framing that issue. And I would also say that EMS leaders continuously and for as long as I can remember, anecdotally have always cited EMS documentation as one of their biggest sources of frustration and biggest challenges. Well, folks, now we have data to back up that anecdotal frustration. Shannon and I, with significant assistance from Matt Zavodsky, served as the principal co-investigators of a recent project called the National EMS Documentation Survey. Just last Monday, we released the report on that survey. And in a few weeks, I think on the 24th of July, we're going to do a national webinar rolling out sort of a more detailed look at the results of that survey. But that survey really looked at attitudes toward documentation, toward completion of narratives, collection of data, how much time on task do providers, clinicians have? Do they feel that they have enough? Do they feel that their documentation is high quality? And then we ask similar questions of medical directors, agency leaders, and folks involved in the revenue cycle side. And it's very interesting to see some of the disconnects in the perceptions and biases toward EMS documentation. When you ask EMS leaders, agency leaders, 85% feel that more documentation, training, and education is needed, but a majority of EMS clinicians do not think more training and education is needed. If you ask folks in the billing and compliance side, by overwhelming majorities, they think more education is needed. And then, clinicians, rate their documentation pretty good as it is. We don't think we need too much more education. Thank you very much. So there are some real disconnects that this data reveals. And as I said, that report is out. It is on the PWW Advisory Group website, and you can connect to that through our social media as well. And we do have a webinar coming up in a few weeks, which is free to attend. Shannon, do you want to say anything about the survey before we move on to the leadership strategies?
So no, I think the opportunity to kind of quantify a lot of things that we felt within the industry, I think the survey kind of gives us the ability to kind of visually quantify a lot of those feelings where we think we're doing a good job as clinicians, the billing department doesn't think we're doing a good job at all, and kind of administration is caught in the middle. So I think it provides the industry with a little bit of leverage to kind of put some numbers to what we're feeling.
Yeah, thank you. And in the webinar, we're going to get into more detail on, how providers view narratives versus data, which they see as the more important components of the PCR. As I said, attitudes toward training, attitudes toward documentation quality, perceptions of how much time good documentation should take, and whether different stakeholders believe enough time is afforded in that process. So it's a very interesting cross-section to look at, again, how clinicians, agency leaders, revenue cycle professionals, and medical directors all look at the issues of EMS documentation. With that, let me jump into five specific strategies that I think leaders can play when it comes to improving documentation within their agencies. The first is good old positive feedback. Being positive, being specific, being encouraging to EMS clinicians when it comes to documentation is something that can be implemented pretty quickly and cost nothing. There's no barriers to entry to positive reinforcement. And as human beings, it is no secret that positive feedback generally works better than negative feedback. And I always like to do sort of comparative thought exercises to illustrate these key points. And if you're on the receiving end of these two different interactions with an agency leader, and if you're an EMS clinician, think of how you would respond. You failed to get patient signatures 21% of the time. If you don't do better, we'll have no choice but to discipline or terminate you. Now, of course, words like failed, discipline, terminate, right? Those are the words that jump out of those sentences. And the person on the receiving end of that is going to walk away from that interaction feeling inherently negative. Now, on the other side, if we communicate the exact same information to the person about their signature compliance, capturing patient signatures on PCRs at the time of service, if I say the exact same information, but flip the script and say that your signature compliance has improved to 79% over the past month, that's a 5% uptick over the prior month. You're definitely on track to hit your 90% goal. Keep up the great work. Now, in both of those examples, we've told the clinician that they're not where we want them to be. But in the second example, we did that by framing their progress as positive, even though they're not where we want them to be. The clinician on the receiving end of that is going to feel more inspired, more motivated, more committed to reaching that goal than they would if it was framed in a negative fashion, where that could produce defensiveness, negative reactions, frustration, burnout, all of those negative consequences. So that's just basic, good old positive reinforcement. We can state the same things and we can frame them either negatively or positively. Positive feedback is also more effective when it is specific and when it is measurable over time. I know this group very familiar with objective metrics, but if I simply say, way to go, your documentation is way better, or, you need to step it up with your documentation, it's not good enough. Whether positive or negative, that very vague feedback is not actionable because it's not specific and it's not objective. On the other hand, if I frame that in objective terms, like I would with any performance measures, whether clinical or operational, I can do the same thing for documentation. Last quarter, our frame of reference, when you documented pain as a chief complaint, you had a complete OPQRST narrative 88% of the time. The company average was 79%, so you exceeded it by 9%. right? Now we're being very specific, very objective with measurable performance standards. Shannon, anytime you want to jump in and add any clarifications or amplify anything, please feel free to do that.
Okay, will do.
Thank you. All right. You know, constant criticism, as I said earlier, can lead to burnout, can lead to frustration. But this is the approach that we find that many with leaders, particularly with documentation, take when it comes to feedback on those issues. And I think that is because it's a source of such continuous, almost generational frustration that, you know, this has been something that's been part of our DNA in EMS, that, you know, documentation always seems to be needing improvement. And I think a lot of it comes from that historical continuous frustration. So that, you know, in this, you know, this cartoon here says you misspelled constant criticism, you know, the guy that's hanging himself. So it's that same type of constant frustration-oriented feedback that can be interpreted in that negative fashion. When criticism is necessary, and sometimes it can be more impactful when it is used more sparingly. I always like to tell the story of how my late father, was a very calm, reasoned, measured guy. If only I inherited all those traits. So when he did have to emphasize something or raise his voice, which he did not do often at all, you could bet that my siblings and I paid more attention, right? Because he was not the kind of guy that walked around raising his voice or yelling at us or that kind of stuff. So when he did make a point for emphasis, as I like to say, it was that much more impactful. It's always good, you know, when we talk about criticism, to do that one-on-one, but on the other hand, universal praise in public is almost universally accepted and recognized when folks are positively noted for accomplishments or achievement. Most folks will universally welcome that. This again costs virtually nothing, but can pay big dividends. You know, the following staff members exceeded 90%, you know, on this particular metric, or whatever the case may be. Fantastic job. And we can also incentivize or note specific objective targets. Some agencies tie monetary rewards to that. Now, as an attorney, I would say caution, right? We should not ever link monetary rewards to whether a PCR is billable, for example, or whether I've, you know, documented a trip as medically necessary, right? We don't want to give inappropriate incentives, but when I tie those to measurable objective outcomes, like your demographic section of your PCRs were complete, you know, 90% of the time, your chest pain narratives documented OP-QRST 100% of the time, right? We can tie, and they don't have to be huge monetary rewards, gift cards, you know, a cup of coffee at Dunkin', you know, whatever or Starbucks, whatever floats your goat, as my kids used to say. But, you know, those kinds of things can always be meaningful and impactful as well. Second thing is to practice what we call clinical documentation improvement. That, again, is a process that looks at specific measurable charting objectives, tracks improvement over time. And just like tracking any good performance metrics, those are bolstered when they are specific, measurable, and objective. And just as we are framing clinical performance or operational performance metrics, the same is true for documentation metrics. And, you know, we always recommend that we start with, what type of services do your agency provide? Do you do a lot of non-emergencies? Are you solely 911? Look at your data. What are your data telling you? Do you have a lot of calls, you know, a lot of charts in chest pain, abdominal pain, back pain, you know, overdose, whatever it is? And then with your clinical leadership, your medical director, your CQI folks, and your clinical leaders, sit down and develop a list of criteria that if this chief complaint is presented, we should see these documentation elements, whether they're positive or negative, right? Whether they are, whether the patient reports these symptoms or doesn't, the clinician documents whether they are present or not. That way we know that those conditions were assessed and then documented. So if the chief complaint is chest pain, and clinically we know we always want to see these 8 or 10 or 12 elements documented on a PCR, whether they're negatives or positives, as reported by the patient. Then once we develop those specific criteria that are condition specific, we can then track individual clinician performance on documentation, just as we would with any other clinical or operational performance metrics. Once we do that, we can then give very specific feedback. So for example, if I look at a particular clinician's chest pain assessment documentation for the first quarter of 2025, and I can identify the things that I've spelled out as necessary elements of that documentation. You documented a cardiac history 91% of the time. Quality of pain, sharp, dull, stabbing, aching, tearing, burning, etc. You did that 47% of the time. Whether the pain was focused or radiated, you did that 76% of the time. You documented associated nausea and vomiting 26% of the time, diaphoresis 89% of the time. And then we can dashboard that, right? Because we've refined the specific criteria that are specific for that condition, and then we can track individual clinician performance on those documentation expectations, just as we would with any clinical care. I could do the same thing for documenting interventions. You documented IV initiation, 12 lead capture, nitro administration, post-nitro blood pressure, right? And we can track, again, whatever we clinically decide are those important documentation metrics, then we can turn those into objective performance data, again, like any other clinical or operational performance metric. We can track those over time. They're more meaningful when we're comparing those same metrics over time. I personally am one who believes that, even though we can generate reports that have virtually every metric under the sun on a monthly basis or a weekly basis if we want, I kind of like the idea from a documentation improvement standpoint, when we bite off digestible bits of that each month or each quarter in our documentation improvement process. I think clinicians can be overwhelmed by data. And if we focus this month, this quarter, this half of the year on these specific documentation metrics, tune up our performance in those areas and move on to others in sequence that we decide are important for our organization, I think that can pay dividends as compared to, every metric under the sun in a big honking report every month. Of course, NEMSQA has measures that can also be used as part of our documentation, whether assessment or treatment compliance as well. Third is to practice documentation peer review. This does not have to be an involved, complex process. This, idea of documentation peer review can be as simple as checking each other's work. We know that the simple act of observation itself can change the conduct being observed. The impact, of that observation can change behaviors. Those CDI checklists that we talked about a minute ago can be useful tools in the peer review process, where clinician A is reviewing the chart of clinician B. And instead of saying, well, I think this is great, or I think this needs work, again, that peer review can be framed in terms of specific objective feedback using our CDI checklists. But even without those structured checklists and that formal process, peer review can still spot gaps, errors, inconsistencies. Hey, I noticed on this chart, on the narrative, you wrote the patient was alert and oriented ×4, but in the data field, you put a GCS of 9, right? One of these things needs to be updated or corrected. So we can just spot those errors, those inconsistencies, even in an unstructured documentation peer review process. And I'm also fond of saying that peer review, when it comes to documentation improvement, does not mean that only a paramedic can review a medic's chart and only an EMT should review an EMT's chart. Heaven help us if an EMT finds an error in a paramedic's chart, right? But of course, we can provide valuable feedback between clinicians, even at different levels of licensure or certification. The peer review process we found builds investment in writing better PCRs, improves collaboration between staff, fosters learning at the peer level, and then builds, I think, more comfort into that process, being that it's peer driven. Okay, fourth quick tip here, or leadership example for documentation improvement, is to harness the power of Teams, not the Microsoft app, but the idea of making documentation improvement multidisciplinary. We tend to think of documentation as really solely belonging to the clinical operational side of the house. But I think folks appreciate the fact that documentation really lives at the center of a multi-pronged Venn diagram. That includes the clinicians and the operational side, but it also includes our compliance professionals and our revenue cycle management team. And good documentation really lives in the middle of that diagram. All of those areas of an EMS organization have keen interests in documentation improvement. Yes, it is a patient care report. Yes, it is primarily a clinical document, but we're not going to generate any revenue if it's not good. And we're not going to hold on to that revenue if we're ever audited from a compliance standpoint, if that documentation doesn't hold up, right? So all of our areas of our organization, clinical, operational, compliance, revenue cycle, should be involved in the documentation improvement process. This is in the interest of the entire agency. If clinicians think that it's just the billing office coming down on them for signatures or patient demographic information, I'm a clinician, I don't really care about the billing piece. Well, again, good documentation is in everybody's interest. And I will bet you that each of those clinicians enjoys getting their paycheck. And it's those patient care reports that really directly help the organization generate the revenue it needs to meet payroll and training and equipment and capital expense and all of those other things that keep the lights on and keep the organization functioning. So for that reason, it's good to ensure that our documentation improvement process has active involvement really from the multidisciplinary team within your agency. It's not just an operational or a clinical issue. And if we bring in the compliance folks and the revenue cycle folks to a multidisciplinary clinical documentation improvement process, it will be more meaningful and impactful in our organization. And EMS clinicians have to understand that those other, parts of the organization, whether it's revenue cycle or compliance, do have keen interest in this and are part of the team when it comes to documentation improvement. And as has been said many times, no margin, no mission. So again, that is in the interest of the whole organization. So our CDI committee would ideally be comprised of clinicians, supervisors, QI folks, revenue cycle staff, our organizational compliance officer. You might want to bring your privacy officer in as well. But the idea of this multidisciplinary approach is the point we're making. And I'm sorry, folks, my voice is seems like it's half gone here, but that should also be an open, continuous dialogue between all staff. It should be a continuous process, and everyone involved in that process should be encouraged to bring ideas and suggestions and concerns to the table. I think the responsibility that leaders have in that environment is to then be open-minded. Some people in positions of authority, I purposely didn't say leadership, can be less than welcoming of ideas that come from their so-called subordinates. I'm the manager, I'm the supervisor, I'm the director. Therefore, I must be the smart one in this interaction, right? I'm the person who knows best. Leaders, true leaders, have to be open-minded and recognize that good feedback and ideas and suggestions can come from anywhere and should not be discriminating when it comes to accepting those inputs from folks on that multidisciplinary process. Fifth and finally, before I turn it over to Shannon, is to give your folks the tools they need to succeed when it comes to documentation. Whether we're providing clinical care, whether we are responding in well-maintained vehicles, whether we are protecting our folks from bloodborne pathogens. We need the tools to do the job, and documentation is certainly no exception to that. We need robust EPCR devices that can withstand the punishment we give them in the field. And we have to make sure that our applications are configured for success. We have seen a lot of provider discontent and a lot of compliance and revenue cycle problems, for that matter, arise simply because EPCR applications were not properly configured, right? For one quick example, we've seen where the patient signature piece is captured in the EPCR application. The field was improperly configured to note that as a patient representative signature. So when we pulled the field saying, give me all the chart, patient signatures, oftentimes they would not come up because those were labeled as a field of representative signatures. So it's really important that, we properly select the field, that we make sure our EPCR applications are appropriately configured to achieve the type of success and improvement that we're looking for in our EPCR documentation. Training and education. I think it's important for leaders, most of us most folks who get into EMS leadership have come through the EMS clinical side. And we all know that in our EMT basic training and paramedic school, the education that we get on documentation is very cursory, really only scratches the surface. And most of what EMS clinicians learn is really on the job training and education. And sometimes what we learn on the job are bad habits that get passed down from EMS generation to EMS generation. So, the formal part of EMS documentation education in our profession has really been kind of lacking. Shameless commercial plug here, no doubt, but this is why we developed a few years back the Certified Ambulance Documentation Specialist course. But whether it's that certification program or whether it is a more structured in-house documentation training curriculum, having standardized documentation training that goes beyond that very cursory EMT and paramedic, basic level documentation training is important and can produce a substantial return on investment as well. Last thing before I turn it over to Shannon. And Shannon, this is an area of your professional interest, so feel free to jump in. But that is artificial intelligence, AI. We are seeing now at breakneck speed more incorporation of AI technology into EPCR documentation. We are certainly not anti-AI. In fact, I guess you could say we are pro-AI, but we're also, it's important to keep our eyes wide open that AI should be used really only in the context of applications that integrate AI functionality into those EPCR platforms. And I contrast that with providers, and we have many reports of this, some of you may hear about this as well, where providers, on their own personal electronic devices will put a query out to an open AI platform and say, please write me a patient care report for a 32-year-old male complaining of back pain, or whatever it is. And out on the public internet, we communicate this potentially identifiable information and then receive that back through these open source platforms. That is not what we recommend from the AI utilization perspective.
It is today's version of copy, cut, and paste.
Yeah, exactly. And, the reason we said that, bringing AI in through application-based functionality is because that gives us the HIPAA business associate assurances. It gives us the unique user ID, the confidentiality and security features of those applications, and those are not publicly accessible data generators. Now, I want to just put a little bit of perspective on the AI question when it comes to PCR documentation. Although AI is new, AI is revolutionary, it is not unprecedented because we have had other forms of technologically assisted EPCR completion over the years. Of course, we have voice to text. We have also had over the past, in the past, auto-generated narratives, basically using the data fields to then just generate narrative sentences on an EPCR. And I think it's important to keep perspective that no matter whether it is AI generated, whether it's a pen and paper, whether it's a stylus and a touch screen, whether it's a keyboard, whether it's voice to text, the important common denominator is that all of those are merely input devices. Whether the information is put into a chart with a keyboard, a voice, a pen, a stylus, a touch screen, a drop-down menu, a pick list, or whatever it is, how that information gets into the PCR, in my view, is almost irrelevant. What is important is that at the end of the day, leaders understand that the culture of your organization should reinforce that it is a core expectation that clinicians review those PCRs to make sure that they are complete and accurate. However that information got into the PCR, we have a professional responsibility for clinicians to ensure that that is an accurate reflection of that patient's assessment, care, transport, disposition, etc. And we don't accept the answer that, well, AI put it there, so that's why I thought I had to keep it there, right? We always have that human element to ensure that those charts are complete and accurate representation of the patient interaction. Shannon, do you want to take the screen sharing, or do you want me to just?
You got it. How's that? Can you guys see my screen? Yes. All right. Perfect. Is it the right view?
Yes.
Okay.
Yes, it is.
Don't everybody answer all at the same time.
Visual.
Okay. So to kind of build off of what Doug had talked about in terms of the leadership perspective on documentation, I wanted to kind of build upon that a little bit and also provide a different way of thinking about how we approach the buy-in from the field level. One of the things that we commonly hear all the time is that, and we've seen in the documentation survey, is that, our documentation needs more work, we need to do better, we need to do all these things. But when you look at the perspective from the individual practitioner, I'm doing great. I'm doing fantastic. Nobody's telling me anything but to do better, but nobody's really giving me the how to do better or the why to do better. So I kind of designed this piece called the narrative of narration. And essentially a narrative is the story itself. It's the sequence of events, it's the details of and the act of storytelling. While narration is actually the voice and the perspective. And I think that's the point that we want to take a different look at. So you're all here to hear us speak and to basically tell a story, right? And that's how we view and that's how we live as a society, as a species. There have been great societies that did not use a wheel, but there have never been a society that did not tell stories. When we talk about the things that we want to do from an organizational perspective, when we talk about the change management ideas we have, when we talk about the advances that we want to see happen in mobile integrated healthcare, we're telling a story about how the future can look and should look. And the way that we tell that story matters in how we get the listener's attention to what we're trying to do. Everything that we do is telling a story, but we haven't really changed the narrative of what documentation is and how it actually impacts the end user. So we're going to kind of dig into that a little bit. So stories contain that timeless thread of human connection, right? It's how our brains were wired for reaching out and interacting with others. We tell stories all the time. And if there's anything that any EMS leader has seen or heard, it's war stories. And we can pretty much know the context of a story based on the first line. So what had happened was, is the beginning of any great EMS story. Okay, don't be mad. That's the beginning of I'm going to be probably mad and this is going to cost me some money and something is broken. And then this one time, as you get two paramedics in one room together, that line will pop up as we like to share our stories. We validate ourselves, we validate our personalities, we validate our careers. We do everything through the process of stories. We understand ourselves inescapably in narratives. And more so now, I think it's important that we kind of focus as an industry on that storytelling piece of it. It is a skill that we don't necessarily train enough leaders on, but it is so essential to be able to tell a good story to initiate any type of change management or any type of change of viewpoint. So the viewpoint is what we're trying to change. And again, as you've seen in our political climate now, it doesn't matter how many facts or figures or percentages or charts or graphs that we show any particular person. It's not going to change their opinion of them of the outcome, right? People don't make decisions based on facts, right? And as we kind of see, a great quote by John Gilbreth, faced with a choice between changing one's mind and proving there's no need to do so, almost everyone gets busy on the proof that they don't need to change their mind, right? So how do we as EMS leaders change the narrative of the narrative aspect of it? And that is essentially telling a different story and taking a different approach to the stories that we're telling. So what is a good story? A good story creates an experience that evokes an emotional response. And I think that is the most important key. So when we talk about leadership skills and we talk about how do we improve today's leaders, how do we prepare for tomorrow's leaders, eventually EQ was always going to come into that conversation, that emotional intelligence aspect of it. Well, that emotional response is essential, especially in that storytelling, because it's emotion and imagination that can rewire our brains, right? We don't make decisions on all the facts and figures and stats and percentages. We make decisions based on how we feel and what we can think and how we see. So as EMS leaders, the whole aspect of the narration is a part of the EPCR, and we have to do this because we need to get paid. That is one way of looking at it, but is not a convincing narration that drives an emotional aspect of it. So when we talk about EMS storytelling, there's a great quote by Seth Godin that says, "People don't believe what you tell them. They rarely believe what you show them. They often believe what their friends tell them, or the internet in this case. They always believe what they tell themselves." So as good leaders, our goal should be to give people stories that they can tell themselves, stories about the future and stories about change. So when we talk about driving and changing the narration aspect of it and getting that buy-in, how do we kind of approach a different narrative for EPCR documentation? And I think this goes back to essentially what is a narrative, right? It's not just a form of record keeping. We got to kind of get rid of that mindset and get back to what it really is at its roots. And that is clinical storytelling. It's a clinical story that transforms a series of observations and interventions into a coherent story that captures the full context of the patient's experience, right? And this is when Doug talks about the AI piece of it, this is where I get a little bit skittish, and I am just an AI junkie. I love and learning anything and everything I can about AI. And I use AI. I'm still a clinician. I use AI to kind of on the EPCR forms. We use ESO where I work, and we're utilizing it. And I like to see what AI creates compared to what I would essentially write. And what we have found is that AI does simplify the how of documentation, but it also kind of undermines that why, the whole premise of clinical storytelling, which is that provides that depth of clinical reasoning, treatment justification, critical information conveyance, all of those things that go into telling a good story, right? So how do we take all of this information? How do we change the narrative of the EPCR documentation piece of it? Well, the new American classic, especially after the One Big Beautiful Bill, is there are two types of debts that Americans will never.
Whole thing started off with.
There are two types of debt that Americans can never get out of underneath: student loans and medical debt, right? We all know this. And the narrative that we started to use with some of our staff is that it is of little clinical value to provide good clinical care, to provide good quality, timely clinical care, only to poorly document, leaving our patients with crippling, overwhelming, and oftenly inescapable debt, right? Our primary goal is primum non sera, first do no harm. So the story that we need to start telling is that to take care of a person is to take care of the entire person, their physical health, their mental health, their emotional health, and yes, their financial health. Because what we do in that time that we spend with our patient matters to their clinical and physiologic well-being. But deep down and in the back of their minds, it also impacts their financial well-being. All of us have seen the calls increase where people with high deductible insurance plans just call 911 to see if they should go to the hospital. They want somebody to put eyes on them to let them know, is their medical condition serious enough? They're doing that because they know that the financial consequences of going to the emergency room are severe, and they may be crippling when, especially when most of Americans are living paycheck to paycheck. So the story that we start to tell about clinical documentation is its ability to help us take care of the entire patient. And for those in the billing world, they see this all the time, but we're not sharing those good stories, right? Where are the stories when Doug talked about kind of that positive reinforcement aspect of it? Hey, I'm just letting you know that Mrs. Jones Insurance denied her claim. She would have been responsible for $1,800 on a fixed income. This would have been devastating. However, your narrative was amazing, and the billing team was able to battle and win the denial, right? So that kind of that Sun Tzu piece of it, the enemy of my enemy is my friend, we have to be able to show that we're positively impacting the patient and providing value and making sure that we don't bankrupt our patients that we're privileged to serve is one piece of that. And it needs to be that holistic approach to care that is part of the EMS documentation piece of it. And everybody, every paramedic wants to know that they're doing well. When you ask paramedics why they got into the job, it's because they want to help people. So we need to give them stories that they can tell themselves, right? We need to give them stories that shows that they're making not only a clinical difference, but a holistic difference in their patients' lives. So one of the things that we started talking about was individual KPIs and balanced scorecards, right? We know, and we look at all of these NEMSQA quality metrics and things like that. Are we looking at it from an individual standpoint, and are we looking at it from a holistic standpoint? So when we talk about making and allowing for us to give them stories to tell themselves, individual billing documentation rate, the percentage of charts submitted with all the billing required data that was needed, the denial impact rate. Here's your percentage of charges returned due to documentation differences. And or deficiencies, I apologize. And we know that insurance companies are going to kick back denials regardless. But how many of them and what percentage of them are preventable because of documentation? Total dollars billed to a patient due to documentation deficiencies. One of the most impactful things we did as a field training officer program, we embraced the FTO program because essentially that is the first exposure that our clinicians get to the field. And one of the things that we did was we wanted to drive home this holistic message of taking care of the entire patient. So we went to our billing folks and we said, hey, these are our new FTOs. Can you run reports that basically tells us how much in dollars was it cost us, was uncollectible in the past year with this person as the primary author? And we wrote those numbers on cards, and we put their name on the front, we wrote the number on the back, and we put it in front of them. And at the beginning of the FTO training, we started talking about this holistic approach and that understanding that the documentation piece of it is part of patient care. It is part of taking care of the entire patient. And we had them flip their cards over. And it was probably the most profound experience they've had to look at that number, which was in some cases over $500,000. In one case, it was $700,000. But it allows them to tell a story to themselves and to the new recruits coming in that it does make an impact. Signature capture rate for accuracy, treat no transport documentation. This is essential for, especially for the justification for the treat no transport charges and things like that. All of this comes down to changing the narrative of the story that we're telling about what documentation is. It's our ability to tell a good story. And we tell stories over and over again on the same patient in the same transport. We give the patient care report over the radio. That is a story. We give the patient handoff to the emergency department. That is a story. We write the narrative of everything that we did in the PCR. That is the story again. So all of these storytelling aspects of it come down to just the narrative that we're telling ourselves and our staff and the future of EMS, that if we're going to take care of people, we have to take care of the entire person. This started before the passage of the one big beautiful bill, and unfortunately this is the new reality that we're going to have to face, where more and more people are going to lose access to healthcare, and where that burden falls on naturally is going to be EMS. So essentially our ability to tell that story, to ensure that that payment option is, we've done everything that we can to holistically and financially take care of that patient, is done so. And what you have from a buy-in standpoint is you have willing participation. So buy-in comes from ownership. And the only way to get to that ownership piece of it is to tell a story in which the recipient or the listener, in this case, our EMTs and our paramedics, are willing to listen and willing to participate because they do want to help people and they don't want to cause serious injuries. We just need to tell the stories that are already there and already existing to make that clinical storytelling an important part of the clinical care. That's my story. Questions, comments, concerns? Doug, anything to add?
No, nothing to add. We can talk it, toss it back to our host, Matt, if you want to lead any dialogue or Q&A or anything like that, Matt.
He left.
No, I was talking to Christy, as a matter of fact.
Oh, okay.
She had called right at the end of Shannon's thing. All right, questions for the group, for the two experts, I should say.
I have a question for Shannon.
Sure.
So I absolutely love the idea of the cards for the FTOs. What criteria were you looking at when you got those numbers for
So-
the employee?
When we first started this, we didn't have the reports built that we really could scale down to what was preventable and what was not preventable. We just looked at every run they were the primary author on that was considered uncollectible within the past 12 months. We gave them general figures. We've since been able to refine those numbers down and refine the reporting to preventable and non-preventable and things like that. But we just basically gave them a blanket number just to kind of prove the point, so to speak.
Okay. Thank you.
Yeah, absolutely.
Master Mergendahl, thank you for joining. Did you want to share any wisdom and insights from your perch?
No, just sorry I wasn't on at the beginning, but no, everything was great. You know, one of the things that we always talk about is this intersection between operations and billing, and how sometimes it's like a, you know, steel cage match between the ops people and the billing people, and how do you best overcome that? And, you know, the scorecard there is certainly an interesting way to take a look at it. But I think it's the classic time immemorial battle that will never seem to stop with the billing v operations. And any tips like you guys were able to put out there for everyone has been very helpful, and thank you very much.
Thank you.
Sure thing. Thanks for the invite.
If there aren't any other questions, we'll go ahead and wrap up. Just a reminder to everybody as I turn off the recording. Stand by.